Good afternoon and welcome to our briefing, our 14th briefing from Protector Province, BC. We are April 7, 2022. And the title of this briefing is COVID Doesn't Take Any Break, Neither Can We. For those of us who don't know us, Protector Province, BC is a grassroots group of physicians, nurses, health scientists, health policy specialists, and community advocates. We're working together to help people in BC stay safe by sharing accurate information that is evidence-based about the COVID-19 pandemic in BC. And basically, our ultimate goal, like everybody else, is to end this pandemic. My name is Dr. Lynn Filiatro. I'm a retired emergency physician. And I'm a member of Protector Province, BC. I will be co-hosting the first part of the briefing, and Dr. Hardy, our another Protector Province, BC physician, and member of our group, will be hosting the last part and the question and answer and the discussion around our presentation. We're honored to get today to have as one of our guests, a returning guest, in fact, Dr. Gosha Gasparovich, who is a developmental biologist from the University of Calgary and the co-founder of Zero COVID Canada. She was a member of Protector Province, Alberta, and also the World Health Network, COVID is Airborne, and Go for Zero. Welcome, Dr. Gasparovich. It's fitting that you're here today as we will continue our conversation where we left off back on December 12th. But before we move on, I just want to respectfully acknowledge that our team is broadcasting from the traditional, ancestral, and unceded territory of the Coast Salish peoples, specifically the Musqueam, the Squamish, and the Tsleil-Waututh nations. We are grateful to the Indigenous peoples who have cared for these lands since time immemorial. As settlers, we commit to do our utmost to uphold the Truth and Reconciliation Commission and work towards its 94 calls for action. Next slides. So today's topic is going to be continuing the conversation we had. In fact, it was back on December 12th. And we'll see what happened since we last saw you, Dr. Gasparovich. And then we'll look at where is BC now as we enter another phase, this time with the BA2 subvariant of Omicron. All right, next slide. So the last time we saw each other on December 12th, Dr. Gasparovich, this was the prediction from the government or the BC CDC as to what we were to expect with the Omicron wave that was starting back in December.
Yes, so that was the prediction that presented by BC CDC. And as we can see, there are optimistic and less optimistic curves there. And basically they predicted that in several weeks there will be 2,000 cases. So in case of the purple line, if Omicron would have higher transmission and immune evasion, which we knew at this time that it is true that it both had higher transmission and immune evasion, then the purple line would be the most probable one. But they also had this optimistic green and yellow and orange line, and the purple line would reach around 2,000 cases at the very end of December. And at this time, December 12th, I think it was December 12th when we met last time. So next slide, please. So that was prediction I did at that time for BC. having really very limited data. So basically knowing the R value for Delta, so the blue line, which was publicly reported, and knowing that from other jurisdictions that transmission advantage of Omicron over Delta could be 3 times or 4.7 times. So basically I multiplied the R value of Delta by 4.7 or by 3 and got these two projective lines, orange lines for Omicron. And also we didn't know, because the reporting was so limited at that time, so we didn't know how many Omicron cases there were in the community in BC. So I just made a guess that, okay, maybe on December 12th, we had five Omicron cases. And so that was the starting point. And then with the R value, I did these projections. And the assumption was that the doubling time of Omicron would be 2 to 3 days, which was observed in some other jurisdictions. And then what really happened, we can I have next slide, please? So here, so important here is that here the y-axis is doubled to the compared to the previous slide. The black dots are based on reported cases in BC, the real ones, so 7 days average, and we see that we actually reached more than 4,400 cases on January 4th on average, and the real slope was less steep than the predicted, but the cases started to grow, the Omicron started to grow earlier. And what it showed when we compared it to BC CDC projection, next slide, please. Well, they are not on this graph, but the real cases were above the purple line. So basically the most pessimistic projection from BC CDC was over optimistic. So we had much higher numbers earlier. And also it's important to know that the reported cases are not the real cases. So knowing reported cases, we can know what trends are, if they are going up or going down, and how fast they are going up or down. But sometime in winter, we started to have much less, BC and Alberta as well, started to have much less testing. So actually reported cases, like the real values are much higher.
Yes, and our premier John Horgan did mention that in December we did hit 35,000 cases, which goes with your point. Okay, next slide. So what we put here is the situation in England, and this basically represents the hospital admissions in England. The first highest peak that you see back in end of December, January, this was Omicron, the original BA1 Omicron cases. And now they have entered and are well into their BA2 phase. And what we can see here is that the number of admissions during their BA2 phase, so the last number is April 2nd, 2022, has surpassed the number of admission that they saw back in December, January with the original Omicron. And the other thing that we see in this slide is that the number in the turquoise at the bottom of the graph along the x-axis represents the admission for the children from 0 to 5. And you can see that the number of admissions were much higher during Omicron than any previous phase for that age category, the 0 to 5-year-old. And again, in BA2, admissions in children have also gone up during that phase. Next slide, please. So here what we are showing is the reported deaths. In this case, it's both England and Wales, and it's up to the week of March 18, 2022. And you see that despite everybody saying that apparently Omicron was going to be mild, you can see that the number of deaths that were registered surpassed the number of deaths, the peak number of deaths during the Delta wave in England and Wales. Next slide, please. So this brings us to British Columbia. And so this is a slide courtesy of the BC COVID-19 modeling group that they just published yesterday. And if we look in green, is the top line shows the number of cases that were reported in BC. Again, an underestimation because we decreased significantly the number of testing. But you can see that with Omicron, the number of cases reported far exceeded those with Delta. And then the second line below, the darker green, shows our hospitalization with Omicron, which again surpass those during the Delta wave. And note that just before the rise in hospitalization with Omicron, we were already sitting high in terms of number of cases in hospitals. And that was because, as you remember, BC had a big Delta wave after its best summer ever, where we removed masks protection. So when Omicron started, we already had patients still in hospital from Delta. And if you look at both these green lines, you can see that they're turning up right now as BA2 is starting. Our ICU admission, however, are continuing to go down at this time because, as you know, it's a lagging indicator. Next slide, please. So this I took from the BC COVID situation report, and as you know, we're always behind. So this is March 19th, 2022. And you can see that the weekly COVID-19 hospital deaths by age group was higher in Omicron versus Delta. Similar situation that we saw in the previous graph with England and Wales. Now, we know that we know that in the last 3 months, our number of deaths has increased by 24% in BC. And we also know that the number of deaths cumulative from Omicron represents about 19% of all deaths that we saw in BC since the start of the pandemic. And that is during the mild, quote unquote, Omicron wave. Next slide. So when Omicron started, I just wanted to highlight that these were the public health orders, or what we like to call protective measures that were in place at the time of the start of the Omicron wave back in December in BC. And as you well know, all of these measures have been removed. Next slide. So just before I bring back Gosha, the reason I selected looking at the situation in England versus BC to look at similarities is when I pulled up the vaccination status, which is really important, we are similar. The only difference is we have more vaccination in the younger age group because the UK has done a terrible job protecting their children. But if we look comparatively in greater than 12-year-old in England, the percentage of people with second dose is 86%, and the percentage of the population in England with 3 dose over the age of 12 is 68%. When we compare that with BC, using greater than 18 years old, because we don't have the same categorization, we comparatively with the second dose, we're sitting at 91%, which is higher than 86 in England for second dose. However, for booster, which is critical, as we know, for protection against infection and transmission from Omicron, BC is sitting at 59% in all people over the age of 18 years old, versus England is at 68%. So they are 9% or almost 10% more of their population have received a third dose in the people aged 12 and over. So let's bring back Gosha. This was Dr. Gasparovich, this was the modeling that was presented 2 days ago by our BC CDC or BC government, looking at the number of cases per day currently as the first wave of Omicron is coming down, and then projecting what could possibly happen with BA2. Do you have any comments on this projection?
Yes, so the interesting thing is always this, it's from March to April, like observed cases, that we see this flattening, right? And there is an illusion that cases are under control and they are flat, that nothing is happening, that it's stabilized. And we see it with every wave. It's basically one wave going down, but under it, it's a new wave of new variant, or new wave because the protections were removed, going up. And I made
So just before we go to the other slide, so what you're saying is that situation we are in, that we are told is we are looking good, is actually not really reflective of what's happening with the rise in BA2?
Yeah, exactly. So we are not looking good. This flatness is an illusion. And it's sort of misleading thing that everything, it's like the flatness in between waves. And we know, because we know that the BA2 is growing, so we know that is just the flatness before the next wave coming.
Okay. Next slide, please.
So I try to illustrate this concept, this principle here. So basically, like, our overall cases would be the blue line, and green line is then there are old outbreaks that die out. But if on the vertical line shows the moment when we have either introduction of new variant, or the introduction or the removing protections. So then the red line starts to go up, and the red line represents new outbreaks of new variant, or new outbreaks because we removed protections. But for some time, for several weeks, because we have the going down adds to the going up, and we have this flatness that we can think that, oh, everything is okay, it's flat, it's under control, but actually it's not, because we have this underwave going up. So we always have to watch for the underwave, and we can do it by observing new variants. And we have tools to do it, because now we sequence the variants. So starting from alpha variant, so the UK variant, then with Delta, and now with Omicron and Omicron BA2, we always can see actually this underwave, because we do sequence. So for public health, it's known how much and how fast this underwave is growing. It's just not reported very often, or people are misled to believe that to look only at this blue line that looks flattish, and not at the red line that is going up.
So just to drive the point home, so the green line would be the Omicron coming down, versus the red line is the BA2 cases starting to rise up.
Yes.
And add to that, in BC, we've removed pretty much all protections.
Exactly. So we have two factors, new variant and removal of protections, that will increase the speed of the red line.
Okay. So that gives us the impression that we were in a stable situation, when in fact we're not.
Exactly. Yes.
Okay. Next slide.
So here's the projection I did yesterday for British Columbia. And again, so it shows basically this principle. So the blue line, dark blue line, it's not very well visible here, but it's the observed halving or decrease of Omicron BA1. And knowing the rate of how it decreases, and knowing that in other jurisdictions, it's assumed that BA2 is 40% more transmissible than BA1 Omicron. So I multiplied the rates and got doubling time of 18 days. So it's the red line. And again, like in December, I had to guess the number, or semi-guess the number of BA2 cases in March. So I assumed 700 community cases on March 19th. So I calculated it from proportions that I seen on the graph published by BC CDC. But I don't know the real number. And then there is another projection, the pink or magenta one. So we have purple dots, which are, again, I had to calculate. It's from very erratic reporting of BA2 numbers. So it's from proportion of sequenced BA2 to other variants, and then I could calculate from overall numbers what it would be as total BA2, and extrapolation of the trend would give the pink line. But again, those data are very erratic, and then the doubling time would be 34 days. But anyway, this more pessimistic growth, the red one, would give us 4,000, would give BC 4,000 daily new cases in mid-June.
And again, those are reported cases, not the total cases. Is that correct?
So yeah, that would be reported cases.
Okay, but there'd be a lot more that aren't, because we're not testing. It sounds like not testing is complicating matters for modeling in terms of predicting.
Yeah, definitely it is, especially if the way of testing changes. And I think what complicates here, so trends, even if testing is smaller but is consistent, then one can, from overall cases, if we have just one variant present, the trends one can be calculated quite accurately. But the problem is that we don't have BA2 reporting very, very, very good. And so actually it would be easy to do this extrapolation of the purple line if we would have good data. And for example, in Alberta, actually the reported data are very, very much in line in the extrapolated ones. But here it's difficult to do in BC.
Okay, got it. How does removing of mask mandate or protection factor into your modeling?
So with the red line, I didn't factor it at all. I just assumed the same. So it's simple multiplication, how the cases of Omicron behaved in the situation in February, and how with having a more transmissible variant multiplied by 1.4, there would be the red line. So the changing in protections is not factored in, and also changing in the weather is not factored in. And waning of immunity or more boosters given are also not factored in.
Okay, so lots of other variables to consider that could sway it one way or the other, but likely worse with removing all protections.
And there is this irony of using models like that. If we would believe the most pessimistic one and take it seriously, then it wouldn't happen, and we would actually save a lot of lives. But always the models seem to be, at least the officially published, too optimistic, and there's this aiming for too optimistic, and then the reality turns more pessimistic than the pessimist model. So for me, the take-home message would be to really believe that the red one is true and make everything so the red one won't happen. And then we can end up maybe with the pink line and save many lives, and then have much less cases going into the summer. Then the in-person schools will be closed, more summer activities, and so on. So then maybe we can bend the curve on with much less people dead and infected before that happens.
and get admitted and die or have long
And
COVID.
having
Yeah.
long COVID.
Okay, next slide. Yeah, this was one of my take home from the last BC briefing sounded like part of the reason we were in a good spot was the percentage of individuals that were both vaccinated in BC, plus adding to that it seems that 50% of our population has developed antibodies as a result of previous exposure or infection, and especially so since the advent of Omicron. And the thinking seemed to be that this would put us in a good position as BA2 is starting to happen and thus protect us. But what I found looking at another study in the UK, if we can have the next slide. So this is a study in the UK where they basically follow every 2 weeks asymptomatic healthcare worker and test them to see how many of them are getting reinfected. They started this just before their second wave, and at that time already 30% of the cohort that they are following, it's about 44,000 National Health Service healthcare workers, and they're recruited from about 135 hospitals across the UK. So when they started before their second wave, 30% already at serological markers, or sorry, at PCR, no, it's seropositivity, serological markers, so antibody testing that showed that they had been infected. And what we see is the amount of reinfection in these healthcare workers was exponential, basically, when we look with BA1. Many more healthcare workers ended up getting infected. And there's also a trend looking like the same is going to be happening with BA2. Next slide, please. This slide was published to look, and again, using data this time specifically from England and breaking it down in ages. What is the rate of reinfections by age group? And this may be an underestimation because England uses as definition that reinfection cannot happen before 90 days of the previous positive PCR test. So, and there's some suggestion that, in fact, reinfection may well be happening faster. So if we use their definition, so reinfection can only happen after 90 days, you can see that the percentage of individuals getting reinfected in England as of March 28 is significant, with the highest group being 24% in the 10 to 34 years old getting reinfected. And we don't know what are the consequences of having multiple infections with COVID. Next slide. And again, so this, and there's an article also that I was just forwarded in Nature as well, that showed that yes, in fact, people in England are getting reinfected, and it seemed to be a triple whammy. Immunity was waning from their third dose vaccination. There's been easing of restriction in the UK, just like here in BC. And now we have BA2, which is anywhere from 30 to 50% more transmissible than Omicron was already. And so we are likely going to see the same situation here in BC. Next slide. So what can we do? Well, the protection has not changed. There is nothing that is 100%. And as we have said all along at Protect Our Province BC, we need a vaccine plus strategy, because immunity wanes, and immunity from infection doesn't guarantee protection, as we just saw. And so wearing a mask, wearing the best quality mask, in this case N95, staying outdoors or in well-ventilated indoor spaces, continuing to practice physical distancing to avoid the short-range aerosol, but also the and also long-range aerosol. And then finally, avoiding large gatherings still. Next slide. One of our teammates put together this infographic, which we'll put on our Twitter feed, is the 5 ways to lower our risk as BA2 is upon us. And again, it's the same things we said all along, except now in BC, we still have access. We have access to 5 rapid tests every month. So we encourage everybody to pick those up. We encourage businesses and schools and all public indoor spaces to really take aerosol seriously and start cleaning the air with both ventilation, filtration, and then monitor what the CO2 levels are. And then it's imperative, now that we are in BC, we will get access, our most vulnerable will get access to 4th dose. It's imperative that we protect our most vulnerable. And for anybody that hasn't yet been vaccinated, that they get vaccinated. And if you haven't had your 3rd dose, it's really a 3-dose vaccine against Omicron and against BA2 if we want to stop transmission and make sure we have the best immunity possible as it wanes over time. And next slide. And we encourage you to write to your MLA. As we saw, the White House had Clear the Air Day on March 29th, and it's long overdue to take the same approach that COVID spreads through aerosol here in BC. And if we want to limit, long COVID, and we want to limit the impact on society, we need to change our stance to a more proactive one, which focuses on limiting infection and transmission, not just waiting before hospitals are overwhelmed, because that is too late. And again, we need to be working, and government needs to mandate the latest guidance from ASHRAE in terms of indoor air quality in all public indoor spaces. And we need to do like Belgium does, have CO2 monitors in their bars, their restaurants, their hotels, and all public spaces, so that the public knows that they're not rebreathing shared air. And I think that's it. Next slide. Yeah. And then we'll bring Dr. Hardy for the
Thank you. Thank you. Yeah, but we've got a few questions that have come from a few journalists, but also there are a couple of questions also, Dr. Gooseberwich, that I wanted to ask you, because these are things that just come up a lot in conversation, or we see a lot of people asking sort of what if or what about. So I thought maybe we would just address some of those head on with you, if that's all right. So when I saw the graphs and the modeling, I see very high rates of hospitalization. I see very high rates of death with the first Omicron and now second Omicron coming. We expect it to be the same, possibly higher for lots of different reasons that you explained. But then I also hear people saying, but it's like the flu. So there's really no reason for us to be even having these conversations, because it's just like the flu. And they'll even sometimes show me some numbers that sound convincing, like why this is like the flu or even not as bad as the flu. Can you explain where that confusion comes from, how we get into that kind of a conversation?
Yeah, thank you for this question. So, yeah, I think confusion comes from focusing only on case fatality rate or infection fatality rate. So for every person, like probability of severe outcomes is probability of getting infected times times case fatality rate or probability of severe outcomes. And even if probability of severe outcomes is low, or even if it would be exactly like a flu, which probably is not, then if you multiply it by probability of getting infected, the number gets really huge. So it's not like a flu in these terms, because we have to remember that if we can get infected, if, for example, probability of getting infected is 100%, then we're really in a big danger. And the R value, like infection, grows exponentially. So in short time, we can have a lot of people infected. And the illustration of it is the raw numbers that we have. So within last 3 months of Omicron BA1, in Canada, 7,000 people died of Omicron. And in BC, I think the number is like 600. I compared it with the numbers from Public Health Agency of Canada reported influenza deaths in season 2018-2019, which was 224 in the whole Canada. So there's a big difference between 224 and in the whole year or in the whole season, and 7,000 in just 3 months. So definitely COVID is not like a flu. And another, like epidemiologically, it's also something very important, that like we can hear these statements that, in some moment COVID will be endemic, and then we can treat it like seasonal winter cold season viruses. But that's absolutely wrong, because influenza has the R value much below 2, and it's so close to 1 that when the warmer season comes, it goes below 1. And when R value goes below 1, we have this natural respite, natural fire break that makes fire break of the epidemic until the next cold season. We don't have it for COVID. COVID now, current R value of COVID, R0, is above 8. So we can like it won't be seasonal just because of it. So we will have several waves each year. So we won't have just one wave and then respite and then again a wave next year.
Right. And I think that case fatality rate is also the thing that maybe has caused people to describe Omicron as mild, given that that rate is lower than the alpha or the initial wave. And then it also leads us to have these conversations that the virus is just continuing to change and it's getting less and less severe all the time. And that will eventually, it will just become, again, like a cold, because that's what viruses do. They mutate and they become, less of a problem to society, and that's what we can expect. In fact, that's what we've been told by our medical officers of health in Vancouver Coastal Health. Is there any evidence to support that? What does the evidence say is happening or is likely to happen in the future?
So no, it's not how viruses behave. Like it's not how evolution works. Evolution has a pressure on things. So sometimes it's random when there is no pressure, and when there is a pressure, it selects towards where pressure selects. So for COVID, the pressure is for having more transmissible variant, and to have, so the ones that transmit faster survives and transmits better and infects people. So there is pressure for faster transmission, so higher R value, and the pressure is now because part of the population is vaccinated, so the pressure is to evade the vaccination, evade immunity. So that's where the new variants will be evolving to. And actually the mildness on how much people will be killed by, like how harmful it will be, the selection doesn't go that way, especially that a lot of transmission happens before people die. So what what happens after transmission, it doesn't interest the virus, like because we transmit before we are in trouble. So unless there would be such pressure, but on being less harmful, but maybe when it would kill like 90% of population or something like this. So once it's like super saturated, but we are not there. So and I hope that we will never be there.
Right. So then you're making a good case for why it might be important to have a target of preventing transmission versus our current target, which is to not completely obliterate our hospital system, right? So our current target is to keep our hospitals just functioning okay as they have been, despite all of the problems that we're seeing in healthcare. And that's been our target, as opposed to the target to, not have it spread for all the reasons that you've just explained, and maybe one we haven't highlighted enough today, which is long COVID. That's another way in which this virus is nothing like the flu. The number of people with long-term symptoms is actually quite staggering. Actually, I'm just going to take a second. There was a study, or the data, the COVID UK database was updated today, and they have 1 in 37 people having long COVID. Like that's of the population, not of the people with COVID, of the population. 780,000 people in the UK have had their symptoms for more than a year. I just found this staggering. I wish we had these numbers for Canada. We don't seem to be curious or studying or tracking, but best we can do is see what's happening elsewhere. And Dr. Filiatreault explained why the UK is a reasonable place to be comparing ourselves to. 330,000 of the long COVID cases that they currently have now started during Omicron, and they pointed out that data is still coming because they don't have the data yet from February. So though they're a little ahead of us, there is still data being collected, of course, on long COVID from their first Omicron wave, and the second Omicron wave we wouldn't even have yet because it hasn't been long enough to meet the definition of long COVID. All age groups are increasing, more so in the younger populations. In children 2 to 11 are 1.5 times growing compared to the other age populations, the number of cases of long COVID. Listen to these: 150,000 children in the UK have long COVID, kids aged 2 to 11. 31,000 of them have had symptoms for more than a year. They also noted higher rates in teachers, healthcare workers, social workers, people from low socioeconomic backgrounds, people with poor health. Again, I mean, these, I wish we knew what the incidence was here, but we have no reason to expect it's any better. And so again, real reasons to be, as you say, looking at the worst case scenario, not the best case scenario. We should be, invoking that precautionary principle, as we keep highlighting, especially with Dr. Filiatreault. She's like our hero of the precautionary principle. Why are we not taking this kind of a careful approach to COVID, and why would we want to underplay the risks rather than doing more? So I've got, sorry, go ahead.
Just to be careful, the UK uses in their definition 4 weeks in terms of duration of symptoms.
Yeah,
so to be careful with the comparison.
Yes.
But the point made is that some people in public health have suggested that with Omicron, less people were going to get long COVID, and that is not happening. We're not seeing that. There's no reason to think, that Omicron, because it wasn't as severe as Delta, we're not going to have as much long COVID. That's a myth.
Okay. Yes, thank you. So we've got a couple questions from some reporters, and I just have one final question. Okay, we'll go to that one. We'll go to that one. That's great. So what are the challenges of modeling when there is such a lack of reliable data available right now? And that's from Nick Pescod. You touched on it, but maybe you could elaborate a little bit for us.
Yeah, so knowing something is like actually predicting that there will be a next wave when we have new variant present. is relatively easy, and I was able to predict the fact that there will be alpha wave and then delta wave and then Omicron and now BA2, just by knowing that it's present in the world and then how much faster it spreads than the previous variant, and that it's already present here. So once we know that the new variant is present here and its percentage grows, and that how much more transmissible, that it's more transmissible than previous one, then we know that in several weeks we will have the wave. So there was no, even with alpha, I think the most difficult was or frustrating was with the alpha, because it was almost several months until it was obvious for everybody that we have alpha wave, and it was downplayed, but it was like just observing the growth of alpha. It was clear in February and then absolutely clear in early March that we have this wave, but public health officials downplayed it for a very long time. And yeah, with good data, you can do better modeling. That's absolutely. And now we are really missing with alpha, and then with delta, we had quite a good reporting of the variants. Since Omicron, it's very scattered and very, like, one has to make this treasure hunt almost to get data, which is strange, because we have that it should be absolutely, it should be public. It's not a big deal to publish in some BC CDC webpage the raw numbers and so on, especially the day.
Wow.
And yeah, and another thing is, I think somebody asked about modeling long COVID, if it's possible. I think it's possible to model everything when we have good data, but I don't think we have good data and good tracking of long COVID. Even the fact that it's not warned about at every presser that, hey people, long COVID is dangerous, avoid getting infected. It's almost like it's something that is actively not being talking about.
Mm-hmm.
And so it's again hiding numbers. And with modeling, what is important is that if we would have independent modelers and independent modeling group doing open source modeling, so everybody from outside and their peers can see what the code was, what went into the model, what were the assumptions, so we wouldn't have such wrong models like we had, for example, in Alberta when we opened for summer, like total over-optimistic assumptions, and the decisions were made based on the model that didn't work. But if people could see this model before the decisions were made, it could be questioned. But it seems that it's opposite, that almost first is the decision and then some models are done. But
models to fit the decisions.
Yeah, sort of. It looked like that. Yeah.
The other thing is that by using, I know that in the BC, we are using our admissions, and the problem with that, it's a lagging indicator. So by the time you see the growth in admissions, you already have a problem, and you're already, in exponential growth. And the wastewater is also always delayed as well. We get that a week or 10 days after the fact. So it doesn't seem like that we're able to be 2 steps ahead.
Yeah, but we could be just.
We could, but we could choose to be.
We have enough. There's enough data to really be several steps ahead, but we always pretend that we are not. And
but if I could sort of paraphrase and let me know if I've got this right or not. Yes, the modeling is challenged by all of those things. And yes, we struggle to understand why it would be that we don't have access to high quality data. Yet we are still able to do 2 things. One, observe what's happening in other places around the world, who fortunately for us are often a little ahead in the timing of their waves. And we can use what we learn from them, apply it to the data we have, and still come up with relatively accurate models, as you have done. And we showed that how accurate your modeling ended up being at the beginning or the first Omicron wave. And now we are suspicious that it will be equally or more accurate than what we saw presented this week by the BC government for this second Omicron wave, and we compare that to what we're seeing right now in the UK, there's just no reason for us to believe that it will be any better here. And we've got some suspicions about things that could make it worse, which is mostly the removal of protections. So we've got Omicron rerun minus protections is basically what we're headed for right now. And we saw the highest number of deaths and the highest number of hospitalizations during Omicron 1 than any other wave, and the highest rates of children hospitalizations. And as yet, we don't really know about the long COVID numbers in Canada by wave, but seeing what's happening in UK, we've got no reason to suspect it to be less. So, all right, we've got a couple more questions. Go ahead. What's the next one? Officials say that we have high protection. How significant is our protection from vaccines and previous infection as we lift the protective measures and a new variant runs rampant? This is from Moira. I'm not sure how to say her name, Whiten or Witten, from the TAI. I just call her Moira. Who wants to tackle that one?
I can start. And so the problem we have in BC is that we still have a lot of people that haven't taken their third dose. I think the government or Minister Dix suggested that 68,000 people over the age of 70 still haven't taken their third dose. And in the entire population of BC, I have in my notes that it's about 1.8 million, 1,198,000 in the whole province who have not yet availed themselves of the third dose. So BA2 is coming. We know that 2 doses is not enough. It's a 3-dose vaccine. Plus, add to that, we have our most vulnerable that were immunized at the beginning of November. So that's long-term care, that's people that are who are clinically extremely vulnerable, and our elders in the community that are at 5 months plus. So we've got a whole group of people that are vulnerable right now, and banking on having had Omicron, like a lot of people did, is not protective. We've just shown that the data in the UK and in England that people are getting reinfected, and that includes also healthcare workers, are being reinfected with BA2 as they were recently, even if they were recently infected with BA1. So we're not sitting in a good place. We're at high risk of, again, our hospitals being overwhelmed and our essential services also being impacted. The UK has already shown that the number of absence in healthcare has gone up in terms of healthcare workers right now with BA2. And there was an airline in the UK, I forgot the name, who just canceled about 200 flights because their workers were sick. So we're having another attempt at learning a lesson, it seems.
That question also to me has this little undertone, the way it was presented, I would say, by the BCCDC this week and the NDP, was that we've got herd immunity, or we've got people with super immunity. I'm just wondering, do we have protection? Is there here herd immunity? Is that a thing? Does it exist? Dr. Gasparovitz, maybe you could tackle that one.
Herd immunity for COVID, unfortunately, doesn't exist at this moment. Because our immunity wanes, either immunity from vaccination or immunity from infection. So we cannot get our value below 1 just by vaccines and being infected. That's basically something that won't happen. Though we can get R value below 1 and much below 1 by combination of everything. Like we see it with after Omicron, when the Omicron 1 wave was going down, that the R value was 0.83 for cases. So if we would push it down, like if we would stop transmission completely, then we are in a safe place. And then if we are super high vaccinated, then we won't be at herd immunity, but we could be in herd resilience. So if new cases would come to our province, then they would make an outbreak, but this outbreak would be slower, wouldn't go very, very fast up, but slower. And then with protections added on top, we could quench it.
I like that. Herd resilience. That's a great one. If we had aiming at reducing transmission as low as possible, plus high rates of vaccination, then we may be able to create a situation that we are more resilient, although not immune. Yeah, great.
Yeah, and then we can sustain the status of having no community transmission, even if cases would be imported. And we could sustain it with the resilience from vaccination and also by engineering solutions like cleaning the air and wearing high quality respirator masks.
Absolutely. And pointing out again that cleaning the air is not a restriction in any way. It's a protection and enhancement that does not restrict people's movement, ability to be together. If anything, it enhances it and makes it better. So
it's like filtering water is not a restriction, right?
Exactly. I think we have one more question. The provincial health officer has made it clear they assume everyone will get COVID eventually. How reckless is this, considering the known, suspected, and unknown impacts of infection? Are they right? From Mucky Man from Twitter.
Yeah, so I would say it's anger-inducing thing, because I don't know, like since Omicron 1 started, it almost seems that and especially January, February, that the whole Western world switched into pushing infection on people by various misleading narratives. And this thing that, everybody will get infected, and it's this kind of fatalistic thing is actually promoting the spread, because then people behave as if, okay, I cannot do anything, I will get infected anyway, so I will go and get infected. So it's misleading people because not everybody will need to get, it's not inevitable to get infected. And actually, that's what happened. So this narrative was already spread before, during uprise of Omicron 1. And interestingly, like in US, not everybody got infected with Omicron 1, which I predicted, like that's not a given that everybody will get infected. And it's because like network effects. So, and because it's fast. So once the networks are saturated, it collapses, and people who missed on getting infected won't get infected when the wave goes down. And so now there are those articles, like people, like experts being surprised. Oh, how did it happen that people didn't get infected? Because they didn't have to get infected, because the assumption was wrong, and that was a misleading narrative. And the problem is that, okay, it's almost like saying to people that, okay, you will all get infected, you cannot do anything about it, and then it will be over. That is like undertone of this, or implied message in it. But it doesn't solve anything. Like if you're infected once, you can be infected second time and third time and fourth time and so on. So it's not getting infected and getting over it, but it's just getting infected one more time.
I think a good example of that has been the people who had somebody in their household that got infected. It wasn't a given that everybody was going to be infected. If you'd put in all the precautions from masking, cleaning the air, ventilation, isolating the person, and put all the ventilation possible and imaginable in place, it was possible not to get infected, even if somebody in your household got Omicron.
So if I could recap, you're saying don't get infected with COVID to prevent COVID. That would be a bad plan. Yeah? Yeah, great. Yeah. We had another question pop up. What should BC and individuals be doing right now to protect themselves and their communities? And that's Moira Whiten, the Tyee. I think probably the best bet, this is our last question, why not pull up that slide that you already showed us a little bit earlier, Dr. Filiatreau? Perfect. These are ways that people can work to try to reduce their risk of getting COVID, limiting your contacts, wearing the best quality mask you can, ideally an N95. Things that our government could be doing, which would be supplying those masks to everyone so that they were accessible and free. Cleaning and clearing the air as best you can, meet people outdoors. If you've got, if you must meet someone indoors, if the windows are open, if you've got a HEPA filter, that would be ideal. We're really hopeful that places that are like work and school will be able to be monitoring their airs with CO2 monitors. Maybe individuals will use CO2 monitors as well. We've got excellent information on our website, protectbc.ca, if you'd like to learn a little bit more about how to clean the air. Call your MLA, ask them to have the government provide resources and legislation that would make sure that all the spaces we're going into have clean air. We no longer tolerate having infected water to drink. We no longer want infected air to breathe. Get your vaccines, as many as you can, as often as you can. We're stuck in BC with the restrictive way they're rolled out, but as soon as you're invited, get them. And if you think you should have been invited and you weren't, I strongly encourage you to call the number on the BC CDC website to get your name back on the list. We've seen a few folks who dropped off for technical glitches. So get your vaccines as soon as you possibly can. Pick up your rapid tests because you're going to need them. The sixth wave is here. It started. It's on its way. It's going to be as big as the first Omicron wave. We've got a repeat with less protections. So get those tests because you're going to need them to check yourselves and your loved ones. Also, we've got lots more information on our website, Protect BC, on how to best use the tests and how to make decisions around staying home when you're sick and when it's safe to get back out into the community. So thanks everyone, and in particular, Dr. Gasparovich, it's so good to have you. I thank you so much for your work. It just blows my mind. I'm not a mathematician. I'm not an academic, and I see you pull those numbers together, and I'm both grateful and amazed at what you're capable of, and for sharing it with everyone, sharing it with us here in BC, and hopeful that everyone who's joined in today will be able to share the messages and help protect each other from this next wave of COVID, which, as we know, has been created by policy. So hopefully we'll have some new policy coming soon that will do better. Thanks, everyone. See you next time.
Thank you very much.
Thank you.